I made a video recently about how antipsychotic medication is pretty much inherently unsafe, and I received a thoughtful comment from a viewer by the name of Taylor asking how I felt administering this kind of medication to patients when I know this medication to be unsafe. And yeah, Taylor, that's a question that has frequently crossed my mind and caused many sleepless nights for me. And at one point in my nursing career, I was against antipsychotic medication so much that I thought about just quitting psych nursing altogether. I really felt as though I was doing my patients a disservice and was complicit in hurting them by administering antipsychotic medication. I obviously didn't quit psych nursing, and I think what prevented me from quitting was realizing that even if I leave, the patient is still going to receive the medication just from somebody else who might not give two fucks about them. And so I thought if I were one of the patients and I had to receive, say, an involuntary medication, would I rather receive it from someone like myself, someone who shows a little bit of compassion here and there and isn't afraid to talk with the patients and seems to kind of understand my predicament a little bit, or would I rather just receive it from someone who doesn't really give two shits and is there just to collect a paycheck? And so I chose the former, and I suppose that's what's kept me in mental health nursing. Although I often wonder if it's the correct decision, and I really don't know. I also know my reasoning here isn't the best justification. I mean, there were nurses in World War II who used similar justification, leading their victims to concentration camps or gas chambers. Well, we're doing it with compassion, as they led someone to a gas chamber. And so it obviously doesn't make it right, nor is giving someone an antipsychotic medication the equivalent to what they did in Nazi Germany, but still. Another way I deal with this conundrum is I have hope that perhaps this will be one of the few patients where there is a miraculous change from their psychotic baseline. I've seen it happen where a patient is absolutely disorganized in their speech and it's impossible to have any sort of meaningful conversation with them. And then after a few days of, say, Zyprexa, they're back to their normal selves and their psychosis seems to have subsided. The other way I manage is I advocate. I generally am not afraid to professionally question a doctor's orders, especially if it seems inappropriate for the patient. My most obvious example of this is when I had a patient who was going to receive his first dose of an emergency medication, an involuntary medication, while he was on an admission unit. He was calm and cooperative, and when staff wanted to administer the medication to him, he was out socializing appropriately with a peer in the day hall. So I asked the prescriber of the EMED how his current behavior that we were seeing out in the day hall, she and I together could witness this behavior, which was him just socializing appropriately with a peer, how his current behavior met the criteria for an emergency medication. She told me essentially that he had threatened another staff member that he was going to kill him, and so he would be receiving Zyprexa 10 milligrams orally or intramuscularly. And we debated about this for some time, and against my wishes, he still received the medication. One thing I did learn while working at the state hospital, which is where this incident occurred, is that this kind of advocacy is frowned upon, and I would later be banned from this admission unit for my outspokenness. And so I learned that when you're advocating on behalf of patients, you have to tread carefully when it comes to questioning a doctor's orders. I'm also a big fan about educating patients on side effects of their medication. I generally try to keep the big stuff in mind when I run my nursing groups on medication education and side effects. Like I'll just pretty much talk about constipation, sedation, apathy, metabolic and cardiovascular side effects, and movement side effects are pretty much the things that I'll stick to or that I'll cover during my nursing group. And then after that, I just tell patients if they have further questions about side effects to just come and speak to me on a one-on-one basis. And the reason I do that is that that's a lot of side effects to cover. Even the basics are a lot of side effects to cover, and you cover more than that. It's just really goes, a lot of patients just don't have the attention span and concentration to really focus for that long on side effects. So I just try to get the big stuff out of the way. Anyhow, that's pretty much how I manage administering these kinds of medications. Taylor, I hope that kind of answered your question. Would love some viewer feedback regarding my justifications, and feel free to be as brutally honest as you'd like in the comment section. Thank you so much, and I'll see you on the next video. Bye-bye.